Welcome to the Oxygen and IS YouTube channel, where we bring you videos on installation, maintenance, and various trainings on oxygen equipment and devices. If you have comments and or questions, drop them in the comment section below or write to us info@oxygenalliance.org. Remember to like our videos, subscribe to our channel, and hit the notification bell.
Hello everyone, thank you for joining us for the second part of the Engineering Health Equity series that we had launched at the beginning of the year. Previously we had guests from UNAMHE, and this time around we have actually invited special guests from UNAMHE, which is the Association for Health Engineers from Uganda. So the whole panel is here today, and we'll be building on the conversation that we actually started in our previous call. And today we'll be focusing on looking at what is shaping Uganda's healthcare future. So you're with me today, Mwabi Lungu. I'm currently joining in from Lilongwe, Malawi. I'll be very happy to know where each one of you are joining from. So please just paste your name and location in the chat. You can also share with us your email addresses if you are not added to our emailing list, that we will be able to send you frequent updates. So please paste the location that you have in the chat. So the way we will do this is that I have a couple of questions for our panelists today. So I'll ask them and they'll give us, they'll share with us their experiences and their mind on the different questions I've prepared. For the audience, we'll also give you opportunities at the right time. So if you have questions or you need clarification somewhere, please just write that down, and then at the right time, I'll actually give you a chance to ask a question or seek clarification where necessary. So our main presenters today from UNAMHE, as I already pointed out, we have Dr. Jones, who is actually the president of the association. We have Dr. Robert, who is the Vice President of the association, and we also have Mr. Ronald, who is the Treasurer for the association. I'm told that there are also other members joining us, so I'll actually leave it up to either Dr. Robert or Dr. Jones to introduce the other members, and then we can continue with the panel discussion. But before we actually get to the panel discussion, they have prepared for us a short presentation that they are going to do. So we're going to start with the presentation first, and then we will jump on to the discussion after the presentation. So let me hand it over to Robert. You can introduce yourself and the entire team properly. I know I did do a good job, and then you jump onto the presentation, and then after that, we'll actually proceed with the discussion. So over to you, Robert.
Okay, thank you so much. Good evening, ladies and gentlemen. It's great to be here, and thank you for the invitation on this. I do apologize. I've got a bit of a cough. I might cough every now and again, but please bear with me. I was invited to talk about our work. What we basically the way things are in Uganda, looking at the landscape of medical equipment in general, and we were invited as the UNAMHE. So along with me here, we have our president, Dr. Jones of Bonglosh, who is also the dean of biomedical engineering at Mbarara University of Science and Technology. And then we have Mr. Ronald Ogenmungu, who is a senior medical engineer working with NFL, which is supporting Ministry of Health to improve capacity in biomedical engineering, and is also the treasurer of UNAMHE. And we have Mr. Solomon Chana also present, and he is the honorary assistant secretary. So we are very grateful to be speaking to you, and I thought that perhaps it would be nice to start with some sort of brief preamble of slides. Can you see my slides?
Yes, we can.
Yes, you can see.
Okay, thank you. Thank you so much. So UNAMHE stands for Uganda National Association for Medical and Hospital Engineering. And when it was formed, it was quite essential that we keep the medical and hospital engineering, because it was recognized that it's not just the biomedical engineers or clinical engineers that contribute to the engineering services of hospitals in Uganda, and of course, generally in all the hospitals across the world. And I have two pictures there. One is for Engineer Sam Wanda, the gentleman holding a microphone, and has been the president for quite a number of years. And he was also the Assistant Commissioner of Healthcare Infrastructure Division in the Ministry of Health. So the most senior position at the time that you could get as an engineer in charge of hospital engineering in Uganda. And also Mr. Sam, as you can tell, they are both Sam, and one we used to call Sam Senior and the other Sam Junior. And is also a long-standing member of UNAMHE and also long-standing honorary secretary. So the two have really been pushing the flag for UNAMHE for a long time. And we broaden it out a bit and put in some of the leaders so you can see some faces. John's the big picture in the middle. He is the president. I think he'll be able to speak, but I know he wasn't feeling so well as well. But he's on call. And then I am the interim vice president. I wanted to start with an advert because it's our mandate as UNAMHE to really advocate for our affiliated institutions. And this is now the 7th East African Regional Healthcare Conference 2024, which will happen in Mwanza, Tanzania. I think it's November from 20 to 2024. And we encourage people from, it's mainly East African conference, but we encourage as many people to come as possible. Previously, we've hosted it here in Uganda. I was the overall chair. Jones was the scientific chair. And we attracted people as coming from as far as the United States and the United Kingdom. And what also this does, it also summarizes some of the strong affiliations we have with the other associations. So we have from Rwanda, from Kenya, and also Tanzania, Burundi, and so forth. So please take note of this, submit your abstracts. It's a more of a it's supposed to share working experiences from hospitals. So its main target are those engineers and technicians working in hospitals, and they need to share experiences. So please take note of that and get to us in case you need more input to that. Then another one is the IFHE 2024, and this is going to be in Cape Town in South Africa. And it says registration is now open. Please go ahead and register. It's what is happening in October. And this is in line with quite a lot of things that we do as UNAMHE. And giving a bit of background, UNAMHE was started in 1993. And many of us will wonder, wow, that's quite some time. Did we have biomedical engineers then? No, we did not have biomedical engineers as per se, but it was started by people who saw the need to have an association for people working in hospitals or people who have an interest on working in equipment and related infrastructure that's going to end up helping people for patient care. If you saw my first slide, it said that your health is our concern. So we wanted to see that people's health is well catered for. And so it brings together all engineers and technicians working in hospitals or even engineers who are well-wishers. And Engineer Sam Wanda, our immediate past president, is actually a civil engineer. And so that goes on to show that we are a bigger association than just medical engineers. We currently have over 100 members, and I've put there that it's been changing routinely. Sometimes it's a lot more, sometimes maybe a bit less, depending on how active it is. And we've recently been granted a license to vet engineers for professional registration. The board that's mandated by government to register engineers in Uganda is called the Engineering Registration Board. And for many years, it's been going through the Uganda Institute for Professional Engineers. And now UNAMHE has also been gazetted as one of those associations that can vet engineers, maybe within the country, but also those visiting to work as engineers for the hospitals, to be registered by this board, which is a great milestone for us, and shows the relevance that we have to ensuring that this field is well looked after. And we've been able to do all this through local, regional, and international organizations. Hence the reason I started with advertising some of the conferences that we see coming up. We are really well in tune with Ministry of Health. Our immediate past president, as I mentioned, was an assistant commissioner. Actually, the offices were in the Ministry of Health as well. Right now, we are sort of in transition, but still within government facilities. And Engineering Registration Board, as I mentioned, the Institute, International Federation for Medical and Biological Engineering, which is worldwide, and then the Federation of the East African Health Engineers Association, FAIR. For this association is the reason why I am advertising the East African Regional Conference, and then the International Federation for Hospital Engineers, and so forth. And so we, UNAMHE, were instrumental in setting up biomedical engineering and biomedical technician training in Uganda. The discussions were started by these gentlemen and women who saw the need to train biomedical engineers, people dedicated to equipment care. And when we train them, the association has also been instrumental in creating jobs, basically lobbying for government to develop a scheme of service and to see that the engineers who are trained by the courses they set up are actually employed. And the objectives, I'll read one by one because I would want us to be clear. We seek to promote among our members the development of science and safe practice of medical and hospital engineering. And, many associations, maybe if you haven't seen this, will say we are an association for maybe medical engineers. And the reason why we keep ours as engineering is because an engineer is sort of a gazetted title, whereas we try to use it in many places. When you call yourself an engineer, is one would know that you are actually a professionally registered engineer. So that's why we say engineering, meaning that everything are associated with engineering. And to promote more efficient operation, maintenance, and safety of hospital engineers, installation, equipment, and building. This fits into the reason why we are called to this panel discussion, to promote the principle on integrated design and evaluation by improved collaboration between professionals and the users. And I think by now I've convinced you that we try to work by collaborations, to promote a better medium of exchange of information and compare national, and national experience through meetings, seminars, and publications. So what we are doing here is definitely among our objectives, and to do all the things the council of the association may consider proper, including advising government, public bodies, and other organizations or individuals on matters concerning medical and hospital engineers, and to do all the things incidental or conducive to the attainment of the above objectives or any of them. So just to summarize what our healthcare system looks like, and maybe this would help us to know how the medical engineers or people concerned with medical engineering, hospital engineering come in. So we have from the village all the way to the national, though this schematic stops at a regional level. And the level of complexity increases as you go up. And this one, we from district hospital downwards, generally we do not find any biomedical engineers situated in this on site. However, we have regional workshops that do outreaches to these lower level health facilities. From the regional referrals up to the national referrals, we have in-house engineers. But as of last year, this system is changing. We also appreciate the need for engineers or technicians in some of these lower level health facilities. And also to get more information, we contributed to a book that was edited by Anasto Yadanza, which is a clinical engineering handbook. This is a huge book, I think, of over 500 or 600 pages. And we wrote about biomedical engineering in Uganda, and it's chapter 27. I believe you can get access to it. And it gives a more summary and more detail of what I'm talking about, but to show that we write what we are doing so that people can know about the experience. And also in that book, we summarized that biomedical engineering is a relatively new field, and we started training in 2007. It's our mandate to know what's going on from training all the way to practice. And for many years, hospital engineering equipment, including medical devices, were managed by engineers and technicians trained in other fields, such as electrical and mechanical engineering. This went up to some extent, but it had its challenges. And where many people were mentored on job to provide different services. Excuse me. And as of 2019, Uganda had two national referral hospitals. So national referral hospitals have got quite a lot of specialized fields. It had 14 regional referrals, if you can remember the levels I showed to you, and so forth. And the regional referral hospitals have a catchment population of about 3 million people and an average of about 400 beds. And this helps us in planning. For example, in many of these regional referral hospitals, at the time we found that maybe there will be one biomedical engineer and maybe some other engineers and technicians. There was always a debate, is this enough or should we have more? Average, and the general hospitals would have a bed capacity of 135. And biomedical engineers, as I mentioned, start at levels of regional referral hospitals. And as of 2019, we had about 100 degree graduates and over 200 diplomas, because we started with diplomas. And we started taking on biomedical engineers in government service in 2016. As of now, before the national referral hospitals were 2, now we have 4, according to the Ministry of Health. And there's also what we've called the specialized, super specialized hospitals. We have 5 of those. And the regional referral hospitals have increased from 14 to 17. And the general hospitals, some of these are the ones being converted into the regional referral hospitals. This is a guesstimate. I know that there's over 200 degree holders, because now other universities such as Mbarara, where Jones is based, and Chambogo are producing graduates every year. And I believe the diplomas, holders intake, the diploma has reduced, so they don't take in as many diplomas as they do for degrees. And some of the activities we've been engaged in, and I want you to pay attention. I hope you can see my cursor to the Global Clinical Engineering Day, which is in October 21st. We've always done something here, and we share to the rest of the world, because this is an international day that is celebrated, and I encourage all of us here. We are here because we are interested in engineering, biomedical engineering, medical devices, to take part in celebrating this day in whichever way. And we've run conferences. We had the Uganda National Biomedical Engineering Conference 2019. We also hosted the 6th East African Regional Conference, the one that's now going in Tanzania. You can tell that ours was in 2018. It's meant to run every 2 years, but we had that break of COVID. And these are some of the female members of UNAMHE who have been contributing over the years on different activities. And also we produce newsletters where we talk about topics on a day. And this can be maybe something got from elsewhere, and then we want the audience to know what's going on, like COVID-19. I think everyone needed to talk about COVID-19 because it was a big issue. But also what we get is a newsletter, though it's not here, the newsletter from medical devices section of World Health Organization that we share with our colleagues and our members here. And there are lots of guidelines, there are lots of tips, there are also lots of, excuse me, there are also lots of opportunities, jobs, consultancies, and so forth. So we as UNAMHE encourage people to really take part and join the combined efforts in trying to develop the field in general. And this picture was taken in 2018, and you can see Jones is right here, our former president, immediate past president, and myself. So we've been working for some time. We worked a lot more even before that time. So that's the end of my slide. I hope I haven't taken up so much time, but I thought it would be good to give that preamble. Thank you.
Thank you so much, Robert, for that presentation. That was it was necessary. I think it was good to also just get a background on some of the work that UNAMHE does and a bit of history as to where we're coming from. So for the adverts that you shared at the beginning, if you can also share those with us, we can also help to spread the word on our platforms. And congratulations for being gazetted as one of the bodies of certifying the engineers. I think it's a great milestone indeed. All right. So I know some people were telling me in the background that they didn't really see the slides changing. We apologize for that. So I think, Robert, you can just share the slides and then we'll actually add them to the recording afterwards. So if someone needs to reference something, then they'll just reference the recording of the video, just so we save on some time.
Yeah.
All right, great. So now let's jump on to the discussion part. Firstly, let's focus on the current state of biomedical equipment, health diagnostics, and healthcare technology management in Uganda. What are some of the most pressing needs and exciting opportunities that you see in this landscape?
Maybe I can invite Jones to start if you can hear us.
Yeah, yes,
yeah. I am here. Like I greet everyone. Good evening, good morning, good afternoon, from where you are. Like Robert told you earlier, I'm kind of not feeling well, so I was actually from my way from the hospital, and this meeting got me on the way, so I parked somewhere to, to have this meeting. But thank you. I am glad to be a part of this. It is good to be part of a more global regional initiative like Oxygen Alliance is doing. And as UNAMHE, we are proud to tag along and offer any assistance and leadership that we can at our own level. You asked about some of the needs for medical devices that that we currently see, and you will correct me if I didn't hear the question very well. But looking at our landscape for medical technologies in the country at the moment, in Uganda here, we have been struggling all along with the issue of maintenance of devices within the country in the different hospitals that we have and things like that. And many of those struggles are related to expertise and access to spares for those devices. We are slowly bridging the gap of expertise now. You've seen in the presentation by Dr. Robert, a number of institutions are training biomedical engineers at the moment. So the gap for expertise is a little bit closing down. However, we still lack a little bit of specialized expertise for special kind of equipment because, as we know, we don't do manufacturing, so you cannot really have what you would call factory-based kind of training. And many of our graduates end up learning more on faulty before you can get a job somewhere to a hospital or an organization where you can now work with working equipment. But most of your learning is on faulty equipment. Which I think is also a little bit of a challenge because then sometimes you might not know what a good equipment looks like if you're only working with faulty ones. So, but the challenge still remains on accessibility for those spare parts. And as you know, that the medical device industry is market driven, if I would say. So if a country is only a small segment of the global market, it might not be worthwhile to stock spares for certain devices within the country, because then you might finish as a vendor, you might finish a year before anybody buying a spare part. So you normally then would wait until people need them before you bring them. So sometimes the downtime of equipment can be very high because you are waiting for spares that are coming from outside of the country. So those are some of the challenges that we have at the moment and that we see in our practice, and it is across many hospitals. I would invite any of my colleagues to add on, and if I didn't understand the question very well, you can as well try to rephrase it for us. Thank you.
Thank you, Dr. Jones. I think that was nicely put. Maybe as I am waiting for some of your colleagues to also comment on, just to build up a follow-up question on one issue that you have talked about on the challenge that is there with actually bringing in spare parts for some of the equipments. Does the ministry or maybe the association, do you actually have some policies in place which actually regulates the number of models or brands that you have of the equipment? Because sometimes when you are dealing with fewer brands, it helps with actually the availability of spares, because you normally look at few.
Yes. So the country has an advisory board.
Machines to worry about.
Okay, sure. The country has an advisory board, which we call the National Advisory Committee on Medical Devices. So this committee, UNAMHE, takes participation. The committee advises the ministry on the types of devices to buy within the country, but there is no policy that specifies that only these brands should be procured within the within the country or even in the hospital. And even in our procurement, when we try to buy equipment, when you are making a requisition for devices to be procured, you are discouraged from saying, I want, for instance, GE monitors, because I already have GE around. You are not advised to do that, because then you might be portrayed as having an interest in GE and trying to influence the process that GE wins a tender. So you are advised to leave your requisition open, that anybody with a patient monitor, for instance, that fits the specifications can bid to supply that monitor. So in the end, you find that people have 2 pieces from this vendor, 1 piece from this vendor, a couple of pieces from the other vendor. So harmony is not yet possible to do at the moment. So we don't have a specific policy to do that. But we still also, of course, advise that if you have a preference, you can still put it as your preference, but that preference might be overlooked during the process of tendering and procurement. But it is still good to put your voice out there that this is what I would prefer because of the following reasons, but it is not binding. Yeah.
All right, thank you very much for that. I think that is well put. I don't know if there are comments from the others.
Yes, I can come in, and maybe I start by also saying that I was looking through the people attending, and I've seen 2 other members of the executive committee of UNAMHE. One of them is also a top figure in Ministry of Health. Engineer Tadeo Byagagambi is the boss of biomedical engineering at the headquarters of Ministry of Health. So welcome, and I think he can speak on from both angles. And then there's also Jude Odele. You are here, and in a way I was trying to speak less because I did the presentation, but I'm happy to contribute as well. I feel some of the other challenges we get is the equipment are not contextually designed to work in our environment, so they get to break quite a lot. And also, we are generally missing on the continuous professional development, and many of the graduates, in a way, are expected to come in the deep end and start looking after the equipment without so much guidance and mentorship from senior people, mainly because we do not have a clear structure for continuous professional development within the hospitals after graduation. And also, we lack generally in calibration test equipment to help in ensuring that our equipment are working as expected. So the test equipment themselves, if they are available, they are not calibrated, but also the medical equipment themselves for diagnosing and treatment may not be calibrated because of the other challenge as well. And I do call on my other colleagues if you have any additional comments.
Yes, thank you. Let me add something little on the challenges. Over time, you have also noticed the structure of the team to support in maintenance at regional level. You find the human resource capacity is low. Like if a workshop is supposed to have maybe about 10 personnel of various cadres, most times you find the vacancies are not filled, and the team who are supposed to support the facilities in the catchment area have less human resource to cover the entire area. That now means they are not able to do their work effectively in a given period of time. Also, to supplement on what Dr. presented about the policy, I know the policy that we had was way back in 2009, and something was being done to have this amended or improved on. I know today we might have a better understanding. It might be in a very high level where now they are presenting it at a senior level in the ministry. And that policy captured so many things that we hope will make maintenance of medical devices in Uganda better. Let me also give room for, I think, Engineer Tadeo to have some input here. Thank you.
First of all, I want to thank Dr. Robert for the excellent presentation, and our President UNAMHE, Dr. Jones, for the submission. But allow me take you through the background of Ministry of Health. At Ministry of Health, we have a department called Health Infrastructure Department, and this Health Infrastructure Department, it is made up of two divisions. We have a division of Civil and Sanitary Engineering, and it is supposed to be headed by Assistant Commissioner, Civil and Sanitary Engineering. And we also have a division called Biomedical and Electromechanical Engineering Division, which is supposed to be headed by Assistant Commissioner, Biomedical and Electromechanical Engineering, of which I am heading. Then the entire Health Infrastructure Department is supposed to be headed by the Commissioner, Health Infrastructure Department. And we also have, it is under Directorate of Curative Services, where we all report to Director Curative Services. Then at Ministry of Health, so we have a National Medical Equipment Maintenance Center, which is supposed to be headed by a senior biomedical engineer with different cadres, both civil, mechanical, electronics, biomedical, and so on. Then across all the country, as of today, we have 13 regional maintenance workshops, which are supposed to be headed as of the new human resource structure that has been approved. They are supposed to be all headed by senior biomedical engineer. Then we also have different layers of health facilities, as Dr. Robert has illustrated, at district level. So those are the layers of biomedical engineering in the country. And of course, I will not repeat what the doctor said. We also have national medical equipment maintenance units, which are at the national level, at national hospitals and super specialized hospitals. And they are all supposed to be headed by principal biomedical engineer. Then on the side of sustainability, we have tried to ensure that we have strategic sustainable approaches when it comes to biomedical devices. And as we talk right now, we have smartly moved the standardization, and one of the achievements as Minister of Health, we have standardized all diagnostic equipment. Those are laboratory equipment. They are now standardized. We have standardized brands, 1, 2, 3 brands. If you come and you have a brand that you are not going, that is not into our menu, you will excuse us. You will not be permitted to give us that brand. Then for other equipment, we have come up with a national medical equipment maintenance policy guideline, which has already been approved from up to senior management committee, and we are now remaining with one level for approval, that is called senior top management, to approve the national medical equipment maintenance policy guideline. And in simplicity, this guideline, it is showing us, or it is guiding us on how we can sustainably manage the medical device life cycle, right away from planning up to disposal level. And it goes further, states clearly who is going to donate and how is going to donate in our country, in order to achieve what we call cost of ownership. Then it also has the issue of redistribution. We have come to understand that we usually get changes in equipment supply, and we are saying that if we have equipment at the national level, and it is needed at the regional level, we can be able to redistribute this item or this equipment to regional level. Reason being, we are now doing what we call decentralization of specialized services from a national level to follow. As we talk now, we have now decentralized radiology services from a national level to regional level. And as a country, we have bought 14 computed tomography scanner for all regional referral and 1 magnetic resonance imaging for Mbarara Hospital. And in this second phase, we are now going to complete all regional referrals with computed tomography scanner and also magnetic resonance imaging to other regional referrals. Why am I saying this? I'm saying this because we are understanding the need for biomedical engineers. The need for biomedical engineers is now beyond what people used to think, because we need biomedical engineers to manage this. And what we have done as Minister of Health at the country, we have increased the salaries for all biomedical engineers in the country. And as we talk now, a biomedical engineer earns around 4.5 million. That is around 1,000 something dollars per month. And we have also expanded the structure for biomedical engineers up to Health Center 4. And at Health Center 4, we have around 220 Health Center 4 that will really accommodate our biomedical engineers. So the biggest challenges which we are facing as consumers or as the industry is that we have right now skilled manpower. We have biomedical engineers, as Dr. Rob has said, but the hands-on biomedical engineers are lacking. We don't have hands-on biomedical engineers to assist us to ensure that we have a sustainable approach in managing our equipment. And that is one of the challenges that we are facing. We have biomedical engineers who are ready, who are produced in different institutions, but they are not mentored, they are not hands-on to come up with immediate solutions that are needed in our facilities. And as we talk now, the remedy that we have come up with, we hope that it works. We are going to start what we call regional biomedical engineering, a center of excellence, and we hope that it will be in Ministry of Health to ensure that these biomedical engineers that will be produced from training institutions undergo hands-on training to bridge a gap of equipment breakdown, and also reduce the foreigners or the expats who are coming from out of the country to come and work on our equipment. So we want to give timely diagnosis and treatment to our dear patients, and on this note, that's why we are coming up with different models to ensure that we have hands-on biomedical engineers to facilitate in equipment management across the whole country. And I want to thank the training institutions. They have done a very good job. They have given us engineers, they have given us technicians who are ready to be employed in our health facilities. And as the ministry, we are saying, let us remunerate these biomedical engineers and technicians. And the technician in our government setup is already earning 2.2 million. That is around it is around $800 if I've calculated well. And that's a very good remuneration which a government can give. And we are going further to ensure that these technicians as engineers are trained hands-on. And in July, we are sending about 15 biomedical engineers and technicians to Korea to ensure that they learn hands-on and come back and make a change to our medical equipment management. So those are some of the things I can really talk now, and we believe that with time we can share further in order to build a resilient and sustainable approach or ecosystem for medical equipment management in Uganda. I thank you, and back to you.
Yeah, thank you very much, Engineer Tadeo. That has been quite very detailed and needed information for all of us here. I have been seeing, was it Jude putting up your hand? Sorry, Mwavi.
Yes, please.
You, but I had some delay in responding. Yes, please, Jude.
Yes, thank you so much. And it's been great listening to people from different areas of expertise in our exciting field of biomedical engineering. I loved what Dr. John shared about having a significant expansion in the training of the profession in Uganda. It's true, I've gone through the system and I appreciate what we have achieved so far. He also highlighted something on there being a gap on areas like access to spare parts or their distribution, and a gap in manufacturing. My question to Oxygen Alliance has to do with their work and what they are doing currently. Personally, I work in the private sector, and I believe they would help me understand what I do much better. I know that Oxygen Alliance is doing a great job increasing access to medical oxygen in Africa, not just in Uganda. So my question is, what are some of the success stories? What are some of the case studies Oxygen Alliance has implemented in other countries? And how might we adopt this in Uganda? Yes. Thank you. Thank you. And back to you.
Thanks, Jude. I think I'll answer that by saying that I am the country representative for Oxygen Alliance, and I'll definitely answer this. But I think if I do answer it now, it will be taking us off the course. Right now in this session, we are invited as UNAMHE to respond to other questions in relation to biomedical engineering in Uganda and UNAMHE. But I'm happy for me to reach out to you and give you a much more detailed view of what Oxygen Alliance does and can do, but it's much beyond oxygen. We are doing a lot more than just oxygen. Oxygen is just an entry point. Back to you, Mwabi.
All right. Thank you so much, Dr. Robert. Unfortunately, I had a technical difficulty, so thank you for filling in. But I think, yeah, as to you, Jude, as Dr. Robert has put it, I think we can actually talk more of this call so that we also get through the remaining questions that I have for UNAMHE. All right, so let me move on to my next question, seeing at how the time is rushing. Hopefully I'll manage to get them all in. So my next one,
While we possibly you could type the question in the chat if you're having audio problems.
I think there was a question before that I had seen. Let me go back. From Rock Musoli, do you have proper disposal of obsolete medical equipment in Uganda? Who would want to take that on?
Do you want to take on this? Could you highlight some of the disposal procedures that are available in our healthcare system?
Thank you very much about that question. The disposal of our medical devices in our health care systems, the policy procedure is available, and it is categorized in two phases. One is the radioactive disposal of medical devices, which we no longer want to use. And the second category is the normal or non-radioactive medical devices, which are due for disposal. The policy is very clear, and it has been strengthened in the new National Medical Device Policy Guideline that is due to come out, and it is stating clearly the collaborations that we shall have toward this clear disposal of these medical devices, both radioactive and non-radioactive equipment. And we have a collaboration with the Atomic Energy Council, which represents International Energy Atomic Agency, which is situated in Vienna, to ensure that all these radioactive medical devices are safely disposed out of our health facilities. Then we also, in the new policy guideline, it is stating how we can strategically dispose these medical devices to training institutions. And one of the training institutions that will benefit from this obsolete equipment is Makerere University, Mbalala University of Science and Technology, the Chamberlain University, and other training institutions, to ensure that these equipment are put back to use by strengthening the capacity building of our biomedical engineers and technicians. So those are some of the modalities or models that we have put in place to ensure that these equipment are disposed of from our facilities, but still are not destroyed. They are put back to use through capacity building of our continuous biomedical engineering students, and also in the service biomedical engineering engineers and technicians. So the policies really is available, and it is very clear and very keen on how Ministry of Health can strategically dispose radioactive and non-radioactive equipment out of our facilities, as I have stated. Back to you.
Thank you.
Hi, Robert. I don't know if you can hear me now.
Yes, we can.
So let me just go to the next question, and then we can get a few questions from the chat. So this one mostly is about innovation in low resource settings. So as we know, most of the medical equipment in most low and middle income countries is actually imported. So how can we bridge the skills gap in areas like experimentation, prototyping, translation, and scaling to also foster local innovations in the low and middle income countries, specifically Uganda in your case?
I think your question was clear, and to me, as a consumer of medical devices that have been innovated at local base or in Uganda, we need to innovate. We need to strategically look at how we can innovate medical devices or come up with medical devices that are ready to deploy in our health facilities. And on this note, I call upon building what we call the linkage between academia and industry. If we are going to come up with innovations that will help our communities as per diagnosis and treatment of our dear patients are concerned, then we need to work hard to strengthen the relationship, or we need to work hard to strengthen the capability of researchers or academia, so that they are able to link with industry. Because we have a lot of innovations. If I can read for you a statistical data of how many innovations our country has come up with, of which are still in incubation stage, there are so many. Of which are out of incubation stage but are not yet commercialized, there are so many. Reason being, there is no linkage between industry and academia. So to me, I see that if we are to come up with a resilient and sustainable science, technology, and innovation in medical devices, we need to come up together. We know the need of the health sector, what they need, and we innovate basing on the need of the country. And the need of the country is very huge because, as you are aware, we don't have any manufacturing plant in the country. Right away from complicated or complex or high-tech medical devices to basic care medical devices, we don't have any manufacturing plant in the country. And so we depend heavily on equipment that are imported. So that means that if we can work together and understand what is needed in the industry or in the health sector, or innovations that have been manufactured or innovated, which are still in incubation stage, or those which are not yet commercialized, then they will be easily commercialized and deployed in our health sector. So the best approach now is to ensure that we identify the team players, so that by the time any equipment is innovated and commercialized, then adoption rate is high. Otherwise, I want to assure the demand for medical devices right away from diagnosis, rehabilitation, monitoring is very huge in our country. Only that we need now to align our set goals and objectives together so that whatever is done in academia is easily consumed by us who are on the ground. Thank you very much, and back to you. I don't know whether Dr. Lob or Dr. John has any addition on what I have said. Back to you.
Yes, Engineer Tadeo, I think you have almost covered it pretty much well, because for us who are based at the training institutions, that is currently the biggest challenge. How do we transition from prototyping to manufacturing? Like you said, there are no manufacturing plants currently available in the country. So having that fast start is a little bit very expensive. A few months back, we were in talks actually with a company in Kenya about manufacturing of one of our innovations that we thought is good. And then it's like, but the initial investment to get these, have a production line, will probably cost us about $5 million. And when we start manufacturing these, we'll be probably manufacturing 1,000 of them a day. How many can you sell in a day, in a month, in a year, or something like that? So this also calls for a regional market, because then you realize that only Uganda might not be able to consume your innovations fully in a more profitable way. So the business people look at these in a very different angle. They are mostly looking at sales and what is the input and what output do you get, and how many am I able to sell, is there a market, and things like that. For us at the training institutions, we are mostly looking at the relevance. This one is a simple technology, it is relevant for the country, and things like that. When you go into manufacturing, it's a different ball game altogether. So that linkage between academia and manufacturing is very much needed, that people who understand the business language could guide us in how we innovate these technologies. Thank you.
Thank you so much. I've seen a hand from, okay, or maybe that was by accident. It's vanished again.
Yeah, there's a hand.
Engineer. Yeah.
You can hear me. My name is Harun Nyamwamkori. I'm actually from Kenya. You can hear me?
Yes, we can. Please go ahead.
Oh, great. Thank you so much, team. I highly appreciate this convention. I appreciate the presentation from the various team members. Thank you so much. And the first presenters has actually been able to breaking wall and various things mentioned in words production equipment. Seem like once we've been able to get together, discuss the technology, discuss the way forward, I actually looking at Adam see that we shall soon be able to get there. I am just going to make a contribution towards the last item in regards to production. Jones actually been able to put it point they had been able to make a prototype. My question and concern would actually be this particular equipment, this particular machine that you're able to come up together with, and you as you said, you approached a Kenyan production factory or the like. Did it go all the required tests, conformity, the various requirements, the various standard checks? How do you say your equipment was? Would you be able to say that depending on the type and what your system was intended for, did it really, or was it able to give the results that were required? In this case, I would actually wish to say, if those could have gone through, then even if you'd have one equipment, and this equipment go various tests and conformity checks, then would I not believe that this SIGO equipment, could be put in one of the centers, preferably in a local remote centers, and be tested, be confirmed that it can actually be able to give the various requirement and results that are intended. If that becomes the case, then if you would have such an equipment, I think to lobby for its production, to bring together the various teams and to contribute for its production, in my view and in my thoughts, this is something that can happen. So those are my comments and my concerns. Thank you very much.
Okay, thank you. I don't know if you wanted me to respond to that, but just a quick one. Of course, those were some of the questions. What are the standards that you are following? Did you make the equipment according to standards? So when you go into standards now, then you start to realize that even the plastic you use should have been medical grade. The electronics you use, who certified them that they're medical grade electronics and things like that. So it's a little bit a complex field that I think probably the industry knows much better than the academia can do. So I think we need an industry front runner to be able to do some of this.
And maybe just to also build on the same point, maybe Dr. Robert may be in the best position to respond to this one. I was going through one of his papers where he was looking at some challenges to do with getting through the local regulatory systems to get some of these innovations certified. So I have seen someone has also posted that in the chats to say that it is one of the biggest challenges that students normally face. They build on something, very great innovation, but then maybe they don't end up going far with it just because maybe the regulatory bodies either don't have clear procedures or maybe they're not pretty straightforward to navigate. So as an association, how do you deal with such regulatory issues when it comes to new innovations that are coming into the industry?
Wabi, maybe you can repeat your question a little bit.
Yeah, so I was just building on the comment that John's made, looking at the products, how do you get them certified, or how do you ensure that we are actually using the right materials to make sure that we have quality products in the health facilities? So I was mentioning that in one of the papers that I think you co-authored, where you are looking at some of the challenges that are there in the regulatory systems that are there, which are meant to certify some of these products that students work on. And I was also looking at one of the questions or comments that has been made in the chat to say students actually do their best to prototype, but they actually lack their support, or maybe they face challenges in actually getting some of their products that they come up with certified. So my question was, as an association, what are some of the, how do you ensure, or how are you helping such people or such students to actually go through the regulatory bodies to get their prototypes certified and have them on the market?
Yeah, I think as the association, we've been geared towards the practice of biomedical engineering in hospitals more than the bringing in the innovations, though it does not mean that we are not interested. And as Jones has discussed, that with innovations, you really need to ensure that you understand the standards that you are supposed to work against, because they set the bar that you have to follow. And as you've said with one of my papers, it actually feeds into our bigger research perspective, which is trying to translate local innovations into devices that can be used. And we know quite a wealth of information on what would be required. I think from Tadeo's discussion, you can see that the UNAMHE Association is filled with members who are in their capacity have the experience and exposure and perhaps the rights to move things to the next level. And from that perspective, I, for one, as a researcher in biomedical engineering, I'm keen on moving innovations. And so there are standards that we have to follow. So in terms of accreditations and approvals, there's what we call the good manufacturing practice. Here in Uganda, we have a local regulator called National Drug Authority that oversees the introduction of new innovative ideas. And so they would want you to have a certified facility and process. And that brings in a number of international standards that we have to adhere to. And for many years, people have been saying locally available materials. But the challenge with local available materials is they are probably not certified to the standards that we need. And two, even when they are, they might just be in the country by accident. Maybe one person has been using that type of material for their other bigger consumer-based product, and they don't need it anymore. So in a way, you want to be able to ensure that they will be quite sufficient and long-lasting supply of your raw materials and so forth. But in specific to that person, if they are interested in learning more, this is what I do on a day-to-day basis, trying to navigate the regulatory pathways to locally innovated. And locally innovated, going beyond just Uganda borders, I'm interested in seeing how can we improve innovations and translation of the innovations in Africa. So the GMP, good manufacturing practice, I know what's required because I'm taking a couple of devices through them. There's the ISO International Standards 13485, which is specific to medical devices. This gives you even a wider market. And then we are trying for one of the devices to get a CE mark because that's what is more trusted within our countries. And so that we can sell to Uganda, to South Africa, to even Brazil, if because they trust the CE mark better. Yeah, thank you.
Thank you very much, Robert. Engineer Harun, you can comment. I see you at the end.
Thank you, Robert, and the team for these illuminating presentations. I would just wish to get back on the innovation and the production. And when one hears of production and maybe design of medical equipment, you might be coming in with the complex equipment like maybe a ventilator or a defibrillator. But for me, that will not be that big case. I will remember, when we had COVID in Kenya, the issue of a product, a hospital furniture like bed, was a very big deal. There came some people who attempted to make some of those beds, but most of the team and people that were trying to do that were not dominant to medical engineering, and in that case, they were not making reference to the various standards. And as Robert has actually been able to put it, most of those international standards requirement in terms of materials, in terms of safety, in terms of material safety, electrical safety, and the like, the information could actually be available. And I would believe that somebody who is trying to come up with a particular product would definitely make a reference to the various standards, like from material, bringing in together the material, the patient interaction, the infectious control requirements, environmental requirements, and the like, because all those standards and information is available. But you can imagine there did not come out a particular bed, that was displayed from a particular manufacturer, locally, Kenya or any other point. So there are some of those products, including the hospital furnitures, yeah, and the like, you know, the basic equipment that I would wish to brief that this could actually be a start before you get into those complex equipment that will require enhanced inspection and certification. So I believe there could actually, there definitely a start, and maybe opportunity allowing, and you know, I can see from the team that definitely I have not been able to interact with, there is capacity, you know, ability, and you know, the energy to actually be able to make a product. Yeah, as you say, it is a high time that we can also, as East Africa, as Africa, you know, be proud of, you know, something that we can actually be able to do. So thank you very much.
Thank you so much for that. I think that is well explained. So in the interest of time, I see there are a few questions in the chat, but there is one particularly that I would want UNAMHE to respond to, because this is a question from ABEM. So this is the Association of Biomedical Engineers from Malawi. So them being a new association, I think they would want to learn a thing or two from the well-established association. So I will read it out. What is the current number of biomedical clinical engineers and technicians, and comparing to your current membership? So whoever posted this can rephrase it if I haven't presented it the way we envisioned it. And the second part is, what are your plans to ensuring that more members join to maximize the implementation of the objectives of your association? And the last part of the question says, what's your current state of employment for biomedical engineers or technicians, with emphasis in the government and private sector? So let me hand it to the panelists.
I'll have a stab at the at it first, and then maybe colleagues can contribute. The number of members, we said, is around 100. The number of biomedical engineers, and using the word engineer sparingly, because we have very few who are registered engineers, professionally registered as biomedical engineers. But taking engineers as those who have graduated from the engineering schools, I think I can count upward of 300. But then also, as it was put in my presentation, UNAMHE doesn't only take biomedical engineers, it takes all the other engineers and technicians concerned about hospital equipment. And just reading between the lines, I think it's a question of why aren't all the people who graduate in biomedical engineering, at least why aren't they members of UNAMHE? And the answer is associations really are not mandated by any act that you should be a member of any association. And as such, we really have to do the work as an association to ensure that we attract more members. And those are some of the challenges and limitations we've observed over the years. And over the years, we've become a lot more active, and I've shared things such as the conferences that we have organized. When people see that they are quite nice conferences that attract international attendance, they get energized to join. The Clinical Engineering Day, we have different other engagements. Recently, we had a training where actually people were encouraged to pay quite a big sum of money, and we are surprised that the turn-up was really, really good, and is to do with professional registration. And now we think the membership is going to really, really grow exponentially because we've gotten a recognition from the government mandated arm that registers engineers. So anyone who wants to be a professionally registered engineer will have to go through UNAMHE. And that means that it's also an added benefit to be a member. So we know that people are going to join. So I think I'm partly answering what are the plans for maximizing to increase numbers. And so those are the things that we're doing. And when I was introducing us, we said I am an interim vice chair, Tadeo is an interim president, and all the members of the council right now, we are interim. And the mandate is, one of them is to increase membership. And we have a list of activities, really fun-filled activities that bring people. And mainly the young people felt, okay, what's the need? Another thing is membership to an association has fees attached to it. And many young people think, what's the point of me paying this fee? What's the return vis-a-vis paying? Or if I pay, what will I gain? And so those are things that we really realize as limitations, but we are working on it, and we think our strategy is working. Because imagine if any person was not a member of UNAMHE and they attended this session today, do you think they'll go away still not wanting to join? Even I am a member, and I still feel that I should rejoin because, wow, there's quite a lot of information and you know, mentorship that I could potentially gain from such wealth of information and the team that's representing UNAMHE here. So yeah, we are working on it. And current state of employment for biomedical engineers in government hospitals. Let me speak from my own perspective as a trainer of biomedical engineers and also as a head of the biomedical engineering of a program at Makerere that started graduating biomedical engineers. And also now as someone who runs grants where I want to be recruiting some of the people who graduated. I am looking for biomedical engineers to employ, and I am not seeing them. I have another presentation somewhere which talks about all my graduates and where they are, because I track them every year where they end up. And I know majority are in employment in biomedical engineering related fields. There are those who plainly do not want to do biomedical engineering afterwards, which is valid, and it happens in any profession. But as I'm looking for biomedical engineers to employ back in my unit, I'm not seeing any. So yeah, that's my response. I think others can contribute to that as well.
Okay, thank you, Robert. I think I'll chip in just a little. As the state of employment with the government and private sector and things like that, me and Dr. Robert are both trainers. And when we started training biomedical engineers, they were not even recognized yet in the government scheme of service. Through lobbying, they were recognized, and the regional workshops were opened up to employ them. When Engineer Byabagambi was talking a little earlier, he said now the government has opened up to Health Center 4 or to the local rural hospitals. So slowly, the government is expanding the employment of these people because they see their relevance in the health sector. But we are still lobbying on the numbers because the spaces might be opened up, and the regulation, I don't know what the regulations say now, Byabagambi is here, will remind us. Might say we need only one person at a health center for instance. But we are going at we are lobbying to reach a level where the biomeds are not only called to fix equipment when there is a fault, but be at the forefront of providing health care within the facility. Many of the surgeons normally call me and say, but your engineers only appear when we are in a crisis. Why don't they be here with us? We do the operation together. They take care of the equipment, we take care of the patient. When we fail together as a team. So when you reach that approach, you therefore realize that you need many more biomeds, not only to maintain the equipment, but to be at the forefront of providing healthcare in real time. So I think when we reach that level, we will have been able to absorb more than what we are training at the moment. The private health sector is taking quite a number of them. Like Dr. Roberts told you, that sometimes you look and you can't even find those that you wish to recruit. So I think the career path for this level of cadres is still increasing and improving, and the future, I think, is still bright for the profession. Thank you.
Thank you so much, Dr. Jones. I think looking at the time, we are just past the time that we schedule for the Engineering Equity Health series. So I think I'll actually end it here. If someone has a question or a comment, please just paste it in the chat, and then I'll make sure that we get these questions to UNAMHE, and then once they respond, we'll also share the response to you. So
from UNAMHE, is it okay?
Yes, please go ahead.
Thank you. About how UNAMHE, or what UNAMHE is doing to increase its membership, I am lucky to be the Assistant Honorary Secretary in UNAMHE, and I have noticed over the last 90 days that we've been serving as interim that the interest is there. The need for people to join is there. They could be joining in different capacities as students or as professionals. What we are doing as Secretariat to increase membership has been exploring different areas on how we can improve that onboarding process. From the time you make an inquiry of wanting to join the association, all through the process of reviewing your application to when you receive acceptance into the association. It's been a bit lengthy, but we believe that before the end of the year, that process will be reduced to an acceptable time for most of the people who are planning to join the association. And one of the things we wish to do and plan to do is to improve the user friendliness of the UNAMHE website to even accept applications or receive registrations from members. Improving that site will simplify a lot of time or backlog we are having with people who actually have interest, so that between the time I pick interest and the time I want to receive my certificate, my UNAMHE certificate, I don't lose interest because it has taken so long. Thank you.
All right, thank you very much, Jude, for that. I think it was indeed a very important point to make. I hope our colleagues from ABEM have also taken note of that. I'm pretty sure if need be, we can actually get you in touch with UNAMHE, and then you can also maybe discuss a few things to also learn from them. Reaching this far, this marks the end of our panel discussion today. I know we had a lot of questions. We still have a lot of questions, but unfortunately, time is not on our side. If we get another opportunity, we'll try to schedule another session again. But in the meantime, let's stop here for now. I'd like to thank you all for joining us for today's session. It was really wonderful. It was very informative. Hopefully, we're going to see you again next time. We've pasted a link in the chat, a feedback form. Please fill it out before you jump off the call. It will help us to improve the call further and make things more interesting for you. For those of you who didn't share with me your email addresses, so we add you to our mailing list, please do so in the chat so that we share with you the different updates from the Oxygen Alliance. A big thank you to the entire UNAMHE team for making this possible. We are really grateful for the opportunity that you gave us, for the time that you spared for us to have this discussion. So reaching this far, I would like to wish you a good evening, and we'll see each other again in our next talk. So it's goodbye for now.